Hey ReFam, my name's Kate and welcome back to Keeping It Real, the podcast about obscure medical terms that end up being actually really relevant. Today we're talking about spitting sutures, which is when your internal sutures make their way outside the body, not exactly where we want them to be. It's not nearly as harrowing as it sounds and can often be misdiagnosed as something far more nefarious by those not in the know. Today, we talk about how common spitting sutures are, how to know if you actually have one, and why we would never prescribe antibiotics just for kicks. Welcome.
Hi.
Thanks for having us.
Anytime. So today, just wanted to talk about spitting sutures, which is a fun little term I've just learned. To probably start us off, what type of sutures do you use in surgery?
Well, there's lots of different sutures, but the big thing in terms of this topic is really whether they're dissolving or non-dissolving. So I use both. I tend to do the muscle repair with a non-dissolving suture because I like the security that it's going to be stable for a long time. So if it's non-dissolving, that suture material is always there. For the muscle repair, that's usually not an issue because it's so deep, so you don't really feel it. The sutures that I use in the more superficial layers, so in the fascial system, which we've talked about, that's a dissolving stitch, even though that's still quite deep. And that lasts about 3 months. And then in the skin, there's 2 layers of sutures there. Again, that's a dissolving stitch, and they usually last about 6 weeks. We can break down sutures like in different ways, but I think related to this, that's the most relevant.
And what exactly are spitting sutures?
So that's when one of those sutures that are closer to the surface end up on the outside rather than on the inside. And it's usually because interrupted stitches you have to put a knot in. So the way we put them in, you actually start, if anyone's watching, you start deep and then you bring it out closer to the skin. So where you tie in the knot is usually the lowest part of it, so the most internal. But where the knot of that stitch is more bulk of suture material, and so it takes a bit longer to dissolve than the bit that's closer to the surface. So if the knot does then end up becoming closer to the surface, if it gets on the outside, it doesn't dissolve. Like it'll dissolve under the skin faster than on the outside. And it sits there and irritates the edge of the skin, and the body then tries to get rid of it. And oftentimes it's like a little pimple on the stitch line. It's not common, but it's not uncommon either.
Wow.
So patients have hundreds of sutures. It would be extremely uncommon for every single one of those to be problematic. So it would be common to have the odd one in someone that's got long areas of suturing.
Is there other factors that contribute to the suture spitting besides just the knotting, or is that?
I think that's probably mostly it, although patient factors surely play a part because we operate on lots and lots of patients, and some do essentially the same technique in nearly everybody, how you stitch up the skin, and most patients would have no issues, and then there'll be some patients that will have a handful of them. So there must be some ways that different patients' bodies react to that. Probably an area that is slightly more common that I find is in the pubic area, because it's when hair starts to grow back again. Sometimes that can irritate, just like ingrown hairs, but as well as can seem to irritate the stitches in that area a bit more.
And is it always obvious it's a stitch? Like I know you just said it looks like a pimple, but is it?
That's the key question. And the reason is because, and it's one of the reasons we always encourage patients to come and see us if they've got any concerns, because the big thing this gets confused with is a wound infection. So almost invariably it's around 6 weeks because that's when the suture is dissolving. And as Kim said, it's the body's reaction, which is an inflammatory process, which is exactly what an infection is. And so they often mimic each other. And so for people who are inexperienced in dealing with surgical wounds, so GPs very good at everything but don't see as many wounds as what we see, they'll see it, there's a bit of inflammation, there can be a little bit of a discharge, and they think infection, put patients on antibiotics. It's so classic that when we see it, we know what it is, even when patients ring, because they ring around 6 weeks, I think I've got an infection, one little spot, there's a discharge, I know that it's a suture dissolving. And when we say spitting, probably the more accurate medical term is that that's the suture actually dissolving. That's what it can often be confused with an infection. So it's usually much less concerning than what sometimes people think it is.
I know you said that it's not uncommon, it's not common. Ballpark, do you have like a guess at how often you see it?
1% of sutures. So, yeah.
I reckon it's probably less than that.
1% of sutures.
Yeah.
Okay. So if you put in 50 sutures in a patient, so maybe every second patient, I don't know. There's no way of really saying. It's only really at the knot. So those knots are really at the start and end. So there's not actually that. Even though we're putting lots of sutures in, not all of them are with knots. We've talked before that we use the barb sutures to avoid knots in a lot of cases. So the knot is more at risk because it's a bigger bulk of suture material. So the body needs to have more of an inflammatory response. Maybe to go back a step just to explain for everyone, sutures don't magically just break down and disintegrate. It's actually the body breaking it down. So it is actually an inflammatory process that makes the suture. So if you left a suture just sitting on the table, at 6 weeks it wouldn't just disappear. So it's the body's actual response. So it is an inflammatory response, which is why it looks so much like an infection.
I don't know if this is a hard question or not, but if that's what the body does to the suture, obviously because it's a foreign body, how come the non-dissolvable ones don't dissolve? Do we know what they...
Yeah. So fair question. It's the different material that they're made out of.
When did dissolvable sutures come into the game?
I have no idea.
They've been around forever. So they used to be catgut sutures.
So what?
Catgut. So it was cat intestines or something.
Like literally catgut. Every
Literally?
time we talk,
I think so.
the dead bodies, the catgut sutures.
Whereas now they're all basically a synthetic material.
Right.
I think you can still get catgut, but it's pretty rare.
I don't think it's made from cat gut anymore.
No, so the sutures we use, they're basically complex sugars.
Mm-hmm.
So they break down.
Oh, okay.
The ones that are not
like
dissolving,
filler.
similar sort of material. Whereas the non-dissolving, things like nylon, proline, so they're very inert and they don't elicit that sort of same response. So when one of those are spitting or coming to the surface, it's more that the suture is causing the irritation. It's not dissolving. They'll never dissolve. But it's rubbing just under the skin and it's causing some irritation.
And you said that you see people typically 6 weeks after. If obviously some of these last a lot longer, if someone's coming like 4 years down the track with a spitting suture, is that something you ever see?
Funny you should ask. I saw a patient today in a little bit of an unusual situation. I'd done a inverted nipple repair on her about 4 years ago. And for that, I actually would vary to whether I use a permanent suture or a dissolving suture. And for the more severely inverted nipples, I would tend to use a permanent suture. And so she's been totally fine for 4 years, and then just in the last month has had some inflammation and irritation in the area and had an ultrasound that looks like there's suture that's actually causing an inflammatory response around it. So whilst if I used a dissolving suture, it would have completely gone by now for sure. So almost certainly there's the permanent suture that's there, and for whatever reason, possibly breast tissue, because there's ducts, there's connection to the outside, so there's some sort of inflammation and or infection going on. It hasn't popped out through her skin yet, which to a degree I'm a little bit surprised. It settled down and then flared up again. So I'm going to need to do a little procedure on her to explore it and see and get rid of whatever's causing the irritation there for her.
So obviously patients can be pretty worried about it, especially when you're saying a lot of the time it looks like it's a infection. Is it something to be worried about?
No. So it's something to call us about. It's something for us to review because it still could be an infection. It's something that with everything, we would want to see you, because sometimes if it's close to the surface and you can feel the knot, at that point everything's healed and you can just actually snip the knot out, which saves the body having to dissolve it, and then it just settles down. But generally what happens is It comes to the surface, it bursts, it discharges, and then it goes on to heal. And 6 months down the track, you wouldn't have known which part of the scar it was. Alert but not alarmed would be where I'd place it.
Yeah, and when we see patients with that, we give it a good clean, have a really good look with a bright light, and often use forceps just if there's any residual stitch material there, like just pull it out or snip it out. And yeah, they'll generally those tiny little holes will heal up within a day or two.
I was listening to some American surgeons talk, and they were saying that they, even though there's no evidence to support it, they prescribe antibiotics after every surgery, because if they didn't and then somebody got spitting sutures, then they were scared of getting sued because they hadn't prescribed the antibiotics because everybody else does. That sounds like a uniquely American friend of mine. Is that
also
something we do?
like the antibiotics that you have early are not going to change your outcome later. And we're talking about, this process doesn't happen in the first couple of weeks, which is when you'd be having the antibiotics. It's not like those antibiotics that you have then are protective of what's going to happen in the future. Very American. Sounds crazy.
But such a stupid philosophy.
Yeah. Everyone else is doing it.
Having antibiotics is not without risk. So you can have an allergic reaction to an antibiotic. You can develop resistant organisms. So we could put you on an antibiotic for no reason. You then cultivate bugs that are resistant to the common antibiotics. So I'm pretty conservative with antibiotics. Obviously, I'll prescribe them if I think it's an infection, but I want it to be targeted. I want to be the right antibiotics. And I never prescribe antibiotics if there's not a clinical indication. So it's not, patients don't routinely get post-op antibiotics. So there's two reasons. Everyone gets a dose when you go off to sleep. So every case. You give antibiotics if either there's a higher than normal risk for an infection, and for me that's tummy tucks, just because of the belly button, because there's who knows what's lurking in there. Even though we do the antibiotic wash pre-op, and I just think that's much more prone to getting infection. And the other occasion you give antibiotics prophylactically, so preventatively, is if the impact of an infection has a high consequence, and that's with, say, a foreign body, which is, say, an implant. So when you've got a foreign material that you're putting in, you absolutely don't want that to get infected. So even though the risk is low of having an infection, the consequences are high. So you want to avoid that. But for most other surgeries, liposuction, 1 dose, breast reduction, 1 dose, scar revisions, if they're in theatre, 1 dose. The only times I'm doing preventative would be tummy tuck body lifts or implants.
I do actually do breast reduction as well, post-op antibiotics.
Well, you could just wash your hands.
And that too.
She washes her hands. She does.
Always. I just think the breast tissue itself is not necessarily sterile.
The point is, though, we're definitely not doing it because the suture may spit. And there's no correlation because the spitting is 6 weeks later. At most, anybody's getting antibiotics for 5 days.
And it seems so crazy to have
crazy.
4 doctors be like, oh, yeah, no, there's no evidence. Yeah, no, they're definitely not supported. Oh, yeah. Yeah, and they were all saying that. And I was like, what a weird system you guys live in.
Yeah, they're infectious diseases doctors.
And if that was only,
pharmacists must hate them.
If only that was the weirdest thing about America.
Yeah.
God. If you liked that episode, there's plenty more where that came from. Maybe start with some of these or head to our channel for your peek into the mysterious world of plastic surgery.